Okay, great. Thanks everyone for joining. We're going to give, it's right at the top of the hour here. We'll give maybe just 1 or 2 minutes and then we'll launch into it. But thanks everyone for being punctual and on time here. Let's see if anything comes. Okay, great. Bunch of people registered. Perfect. And we got some people trickling in. Great. We'll give it 1 more minute, everyone, and then we'll go ahead and get started. Just in the interest of everyone who was nice and punctual here. Okay, well, we're at a couple minutes past 12 now. So let's go ahead and get started. I think more people will trickle in as they come. So thanks everyone for attending. This is one of our monthly sessions, and the topic today here is hypertension and chronic kidney disease, a giant topic, and we'll go through it here. Just as an introduction, I'm Mike Bevilacqua. I'm a nephrologist over here at Surrey. I also happen to lead our kidney care committee, so that's my other role with BC Renal as well. Before we launch into things, just a few disclosures, which I have listed here. These are some of my relationships, but specifically, none of these are related whatsoever to blood pressure management, and I won't be really talking about anything other than generic topics here. Okay, so blood pressure management in chronic kidney disease is a giant topic. I mean, people do whole fellowships on this thing, so I'll try to do it justice here. And I think these are the items that I wanted to touch on a little bit more. Really, I wanted to talk about the relationship between hypertension and chronic kidney disease because it's a little bit more nuanced, I think, than we sometimes appreciate. And then I'm going to spend actually the biggest part of the session is going to be around some of our things around blood pressure targets and choices of agents, just to give you a bit of an insight and into our thought process as nephrologists when we're talking about who has what blood pressure target and what medications we use. And then lastly, at the end, we'll have a few other considerations about some lifestyle things. And I do want to talk a little bit about measuring blood pressure and specifically home blood pressure monitoring, which is a big topic lately. Okay, but to just launch into it, I don't think any surprises here, especially to you all as the primary care audience, that hypertension is common. It's a very common thing. These are the statistics here, is that about 25% of Canadians, depending on how you define it and what series you look at, somewhere around a quarter of Canadians have hypertension, which is a ridiculous number when you think about it. And another ridiculous number is that 10% of Canadians have some degree of chronic kidney disease. That's always bigger and it always surprises people, but a lot of that probably flies under the radar that isn't quite recognized yet. But when you take all comers with any change in kidney function, it's about 10% of people. And here in BC, we have over 17,000 that we have registered with us with BC Renal with chronic kidney disease, most of these being more advanced. So there's no surprises there. But the other item that I think is really important to emphasize is that over half of our patients, and on some reports, even up to 80% of kidney disease patients have hypertension. And when we look at the numbers for our BC reports, where we see that of those, only 10% have hypertension listed as their sole cause of kidney disease, the relationship that you see unfolding here is that hypertension is common and probably contributes to a lot of kidney disease. But even if somebody doesn't have hypertension as their cause of kidney disease, they often will develop it later, and it'll be a very important management consideration moving forward. So even though it's not the direct cause of everybody, it certainly is one of the biggest things that we do in care of people with kidney disease. We've known for ages that blood pressure is pretty much directly related to renal outcomes. For every increment in higher blood pressure, people do worse as far as their kidney outcomes go. You could draw almost an exact similar figure for cardiovascular outcomes, and that's very, very well known. But it's important to mention this too, that again, regardless of where they're starting from or why they have kidney disease, every degree that their blood pressure goes up is an increased renal risk. So that's not surprising, but the part that I think is worth mentioning is that it's not always a straightforward diagnosis or relationship to say that somebody has hypertensive kidney disease. So what we often think of, the classic we all learn in school in our training, is somebody has hypertension for a long time, often years, if not decades, and then they slowly get hypertensive nephrosclerosis, and now we have chronic kidney disease. And that can be true in a lot of people, but the reason that I have these figures that look quite complicated is that we actually realize that not everybody who has what we call hypertensive nephrosclerosis, or the changes of hypertension in their kidney, have really, really high blood pressure. Or in other words, if we went around and took everybody with kidney disease and did biopsies on them, we would find changes of hypertension in people that maybe never even got recognized as having really, really high blood pressure. And there's reasons for that. There's a whole bunch of microvascular contributors to this. And again, other diseases can interplay. But this is just to say it's not as simple as we only see hypertensive kidney disease in people with really high blood pressure for a long time. We sometimes see it in other times. We used to use a term for this, something called benign angiosclerosis, which I hate that term. What it really meant is that they didn't have changes of malignant hypertension, but I hate the term benign because we would have people go on dialysis for benign nephrosclerosis, which is, of course, is not a benign outcome. So these people do still have bad outcomes, even if they never had high blood pressure. These are some of the items that would make you suggest that, yes, this is all related to hypertension, right? So this is the slam dunk cases, people who have had that high blood pressure for a really long time. They have other hypertensive changes like retinal changes. They have LVH. These are things that obviously paint a picture. So why I have this box at the side, though, is in the absence of this, this is where us as nephrologists want to do a really good screen to make sure we're not missing something else. Because hypertension is so common, it might coexist with a different disease. It's entirely possible to have both hypertension and a glomerular disease just because they're common. You want to make sure we're not missing something else. So that's where we do a screen to look for other causes. Okay, so that's a little bit of the background, but that's the point I wanted to leave people with, really, is to say it's not always as straightforward as what's the chicken and what's the egg, but either way, it's crucial that we manage the hypertension once we've recognized the kidney disease. So now let's manage the hypertension. These are our targets, and there's all kinds of different targets. And what makes it even worse is the different targets have different targets. So depending on who you look at, whether it's Hypertension Canada, or the other one I have here is called KDIGO, which is what we use as nephrologists. This is kind of the nephrology world guidelines. You sometimes see different targets for the blood pressure, which I know is a super confusing point for people not really deep into this world. So what I want to do is take everybody through a little bit of how these targets got developed. So we're going to go through what I'm calling a whirlwind tour of the evidence around hypertension. This is, there's some comments about audio. Maybe Sidoni, from your end, is everything coming through okay? Maybe just a couple of people's connections.
No issues on my end. But...
Okay, great. So, and just in case there's recordings of this too that we put up. So in case there's an issue, we go with there. Okay, great. So yeah, a whirlwind tour of evidence. I mean, again, this could be a many hour talk or many sessions, but what I want to do is go through a bit of it just so we understand where these targets come from, because that'll be important to say, who do we really need to be picky about their specific blood pressure target for? So this one is a picture that people could probably draw in their sleep. It's been known for many ages. This is from the HOT trial of, almost 20,000 patients, hundreds of thousands of patient years of follow-up, where this whole idea of the Goldilocks zone, or the sweet spot for blood pressure control, comes from. And that sweet spot that they had, they could pinpoint it because of such a large trial. That's where that number of 138/86 comes from. And that was the very bottom of that U-shaped curve. The U-shaped curve being that we all know that it kind of, the higher blood pressures is worse outcomes, but you also have worse outcomes in people with really low blood pressure too. So that's that Goldilocks zone. And we've all known about this for quite some time. But there's a few big questions that come out of this, right? Because that's a big trial of all comers. So we really need to know, how do we individualize this? And the first question is lower better in somebody who has kidney disease? Someone who has end organ dysfunction, do we want to actually even be more aggressive? So there have been a lot of trials around this in the renal world. And these are some of the bigger, more landmark ones that we have listed here. I really like this picture where it shows the two different kinds of outcomes, both renal protection and cardio protection. It's very important, it's sometimes odd that as kidney doctors we spend so much time talking about the heart, but the thing to remember there is people with chronic kidney disease don't die of kidney disease. They die of cardiovascular disease. By far, that is the biggest source of their endpoints, right? So this is why actually we look at this as a main driver of our outcomes in even renal trials, is because this is what drives the outcome for a kidney patient. But we have evidence around both kidney outcomes and cardiac outcomes. So let's go into it again. Again, this is going to be a whirlwind tour. I'm going to go through this a bit quickly. The point of the talk here today isn't for you to know all of the trials and be able to quote everything, but just to really see why we pick apart different groups of patients. So this is one of our trials, a RAIN trial, very, very, landmark one, where we had people with non-diabetic kidney disease who were treated with ramipril. And back then, you can see that this is the target they used. You'll see that the targets of what was called intensified or regular blood pressure control changes over the years as our routine care changes over the years, the standard of care. But these are the targets they used. And they didn't really find, too much of a difference there when they look at the outcomes, either intensified or regular control. Okay, great. But let's go on to see, some trials where I actually saw a few things. So this is the MDRD. You can tell just by looking at the font on the New England Journal. This is an old study, but we don't have a lot of landmark trials in nephrology, so we still talk about this one. And so this was non-diabetic kidney disease, and it's called MDRD because there was actually some diet changes that they did. But in addition to that, they did some blood pressure. They use MAP as their target, and this is what it kind of corresponds to here when we convert this. These were patients who were non-diabetic. There was a lot of polycystic disease and a lot of glomerular disease. Okay, so when we look at those two bars, they look pretty similar, right? They're not changed, they're not separating at all. So there was no difference in the whole population, but, and this is the reason this is a landmark trial, in patients who had proteinuria, and that's what these bars down here are. This is in grams per day, less than 1 to 3, or over 3. In patients who had a proteinuria, there definitely was a difference. So the patients who had proteinuria did have a benefit with a lower blood pressure target. This is in terms of their rate of kidney function loss. So a big outcome for our renal patients. And a few other trials went on to look at this similar thing in slightly different populations. I didn't want to talk about all of them because there's a lot of trials here, but this just is a meta-analysis of them, that there was MDRD, this is one of them. The other big one you hear us talking about is ASK, which is in the African-American population, and a few others of non-diabetic kidney disease. And what we've found for these trials is that both of these things, so their blood pressure control and their degree of proteinuria, are both independently related to their outcomes. So people with higher blood pressure do worse, people with higher protein do worse. And the combination of them is more than just additive, it's synergistic. It's a really bad mix to have both really high blood pressure and a lot of protein. And from these meta-analysis, what we can say is that in people, and you can see that's why I like this figure, the ones with the circles, those are the people with less than 1 gram of protein. There is no real difference, but those who have the higher protein, that's where we do start to see a difference if their blood pressure is anything less than aggressively controlled. Okay, so this is all to say that this is why for ages we've talked about, and you sometimes see us in nephrology saying, do they have protein or not? And that influences what we talk about as our target. We'll say that someone with high proteinuria, which really is above a gram per day, should have a target of less than 130/80, whereas you might relax that if they don't have that degree of proteinuria. And this is why we actually do have an evidence base for renal outcomes in patients with higher degree of proteinuria. Below that, there's not really much evidence. I'm going to talk about a new trial later on, but it's really the protein that drives our decision making. And the higher the protein is, the more that becomes a consideration. And you can see that when I'll show it a little bit later on, the grading of all the evidence, but you can see that the higher the protein, the evidence grade gets stronger because we have more evidence that you want to have an aggressive target in people with really, really high protein. Okay. So that's non-diabetic kidney disease. Now, if I singled out non-diabetic, then of course the next question that we ask about, well, what about diabetes? We all know that we often talk about, and you'll see a lot of these different organizations have a different target set for their diabetic patients. Okay, so what's the difference with our diabetic patients? We've known this for ages in diabetes. This is observational data. Ever since way back in the UK PDS, we know that higher blood pressure, you have both worse microvascular and macrovascular outcomes. Microvascular, us being us in the kidney world, we know that higher blood pressure is bad in diabetics. Okay, so that, again, I don't think I need to tell anybody that. But we have, some evidence now with blood pressure targets in diabetic patients with kidney disease. So Advance, one of the trials, again, massive trial that a lot of people know about, where people were treated with a combination of perindopril and dapamide to these two different blood pressure targets. And there was a benefit. Again, sometimes when you relook at this data, you say, well, that's not a low blood pressure target. But back then it was, right? Saying anything less than 140/90 standard blood pressure target, it was considered aiming lower. And when you look at that's for some reason it's a bit fuzzy, but when you look at the bars here, they do clearly separate. That getting to that lower target made a difference in terms of their outcome. This was a combined outcome. Okay, and then so again, the world evolves and we start doing more and more trials. So now ACCORD, this is really what we would call an aggressive blood pressure versus normal target, right? So most of us would be familiar with calling less than 120 a more aggressive one, and 140 being a standard type of target. And this is the blood pressure they achieved. It's always really great when you can see a massive trial and they were able to do what they tried to do, where they were able to get people's blood pressure down. It sounds funny, but it's because some of us are nihilistic in hypertension and kidney disease, of saying, oh, my patients don't get down to that low. And true, this is a study, which is an ideal situation, but they were able to do it with not a giant number of medications, 3.5, which for me as a nephrologist, that's kind of par for the course for some of my patients. But of course, to get to that intensive arm, they did need more medications, right? Which is not a surprise. And what we saw is, okay, so there were a bunch of different outcomes here. So their primary outcome being another one of these composite cardiovascular outcomes. There was no difference between standard and intensive blood pressure lowering. But when you separate it out, and this you see they zoomed in this little inset here because those bars are so overlapping. I don't know why they didn't change the scale. But there was a difference in stroke, which was significant in the more intensive group. But that comes at the trade-off of more adverse events. And that includes things like hypotension and acute kidney injuries, which is very, very relevant, right? And this is now taking us back to that Goldilocks zone, right? This is what we all kind of had in mind before. You push lower, you might make other bad things happen, even if you are protecting from vascular events. So it might sound funny, but that's why in patients with diabetes without proteinuria, which I'll talk about in a second, even though a lot of the guidelines often said push them to lower targets, when we look at the grading of it, which I'll show in a second, the only real strong evidence is in people with proteinuria. In the non-proteinuric patients, it wasn't really clear, and they're kind of more as opinion-based or expert opinion type of guidelines, right? So the way I kind of approach this with some of my diabetic patients is I individualize it a bit. If you've got someone who's younger and doesn't have vascular disease and you think they've got a long duration ahead of them, you might want to be a little bit more aggressive, but you need to know that that comes at the trade-off of potentially having adverse events. So I actually talk to all my patients that if I have decided to be a little bit more aggressive with these non-proteinuric diabetic patients, say, we actually need to look out to make sure it's not going too low. If you start getting lightheaded or dizzy, or if we start seeing their kidney function bouncing around dramatically, telling us they're underperfusing, then we might actually back off. So you can try it, but you need to know that you might back off. And what we do know, and this is where ACCORD comes in, is that going lower, we have more and more evidence that you don't want to do that. There is harm associated with this. So those are diabetic patients without protein. Then, of course, there are diabetic patients who have a fair amount of protein. This is a lot of what I see in my practice. And surprisingly, we have more evidence when it comes to drugs, things like ACE inhibitors and things like that, but not a ton specifically looking at this group. This diabetic high protein population. So the last couple ones we had, they actually either weren't powered or didn't quantify protein, one of the two. But we have some observational data, which I presented earlier. But you'll see then that what we kind of end up doing is extrapolating some of this into the population of diabetics with high protein. So I'll show again, once I'm done this next trial, the grading of the evidence, which I think is important because it tells you how strict we need to be with these. But basically, the way I would summarize it is, I think a lot of us in this world do feel that there probably is more benefit in our diabetic patients with protein, and we will try to get them down to the lower target. But it's just to say that it's not that we have a giant evidence base to base that on. Okay, and then I show this kind of new dawning type picture here because, I still remember when this trial came out, the sprint trial, because it changed every guideline after it came out. This was, an immensely impactful trial. It's hard to think it's over 5 years ago now because we still talk about it as it's a relatively new thing, but it changed everything. It was the sprint trial. So this one is worth going into in a little bit more detail to say exactly what group is it talking about, because it's not a lot of our kidney patients. Okay, so this is Sprint, 2015 in the New England Journal. Very specifically, non-diabetic. So right out the gate, diabetic patients were excluded. A lot of this because of what we had before with ACCORD, where we know that we don't necessarily want to push them as hard, right? So excluded right off the gate. But this was a group of patients at high cardiovascular risk. Important overlap in our kidney world because a lot of our patients with kidney disease have, of course, a lot of cardiovascular risk factors and a lot of kidney disease. Many of us look at it as a cardiac equivalent, right? They are at cardiovascular risk, of course. But specifically, it's just looking at their cardiovascular risk to enroll them. They were then randomized to these two different blood pressure groups. A priori, they did want to include patients with kidney disease, but specifically nobody with protein over 1 gram per day. Leaning on the evidence we have earlier that we talked about with those patients. So you can see already why I wanted to go over this is this excludes a lot of who I see as a nephrologist. This excludes a lot of our kidney patients, no diabetics and nobody with high degree of proteinuria. So this is really talking about non-diabetic, low proteinuric kidney disease patients, if anybody. So again, just like the ACCORD trial, they were able to achieve their target. Again, it took more medications to do so, but not a tremendous amount. I still think, again, as a trial, this is optimistic real world type patients. And, we certainly see patients on a lot more medications than this, but not a giant number of pills. And this trial, as opposed to a lot of the other ones, was actually stopped early because of evidence of overwhelming benefit. Right? It's always worthwhile to reflect on what that means. When we stop on a trial early because of it signal towards harm, that's a very clear thing. Of course, you want to stop it early, but to stop it early because of benefit means it met their predefined outcome where it was so overwhelmingly positive that there was no mathematical chance this could have been a negative trial and it would have been unethical to continue. That's what it means to stop a trial because that's positive, right? So it's worth reflecting just how impressive this is. And you can see this is the difference, not just in the cumulative mixed cardiovascular renal type outcome, but also in mortality. So the patients did much, much better who were in the lower intensive blood pressure arm. Again, they wanted to include CKD. It wasn't specifically powered for them, but there is, a trend towards showing that, yes, this is still working. You see kind of a uniformity in these different hazard ratios here. So it looks to be that the benefits preserved for CKD. And it also looks like some of the other groups we might have thought you would want a looser target, such as the elderly patient over 75. That's one we've always had, if people remember, to something called the HIVET trial. We actually looked at this and said, maybe you do looser control in an elderly patient, but that isn't the case. It seems to be preserved here. But there's always a flip side of the coin here. And I thought I had boxes, but I don't. This comes at an increased risk. And you can see the one here, very, very significant increased risk of acute kidney injury, hypotension, and orthostasis, very specifically. The sodium thing probably goes either along with the medications or with low blood pressure. So again, there's a flip side to this coin here when you're using an aggressive blood pressure target of these items you need to watch out for. And that's why I really go through, when I'm using an aggressive blood pressure target and counsel these patients about it, because you need to know that that's a very real risk that you want to try to mitigate. Okay, so that was my whirlwind review of this. So how do we put this all together? Because there's now so many different groups, and I always found this confusing too, of different targets and different numbers for different people. So to summarize all of this, Sprint is to start from, is since it changed everything, it shows amazing benefit of intensive blood pressure, but it's important to know who it doesn't apply to. It doesn't apply to our diabetic patients. They had some elderly patients over 75. I'd say extremely frail patients, weren't included. So it's important to know that you might not necessarily apply that to that group. And then for the patients in the chronic kidney disease world, there is most evidence in patients with high proteinuria. And the higher the protein, the more you potentially stand to benefit. Okay, so, and my last statement is cut off. It was actually going to say that although a lot of the guidelines say to push a lot of people below 120, a lot of the evidence there is actually not all that firm, right? It's kind of scant to push people that low. So I think my practical approach that I would suggest to people is when you have someone at high vascular risk, if tolerated, make sure to always keep checking in with them, especially shortly after you do this change. You can try to go down to 120 over 80. That's great, but make sure you check in, because if it's not tolerated, knowing there's those risks, that's the individual you want to back off on. That's why we individualize blood pressure targets. Okay, so that's great for your non-diabetic or your non-diabetic and non-kidney disease patients. But for your kidney disease patients, this is the practical approach you see most of us nephrologists take, that we're really much stricter about that lower target of 130 over 80 in those with more protein. And the higher the protein, the more we want to see that. Whereas in non-proteinuric chronic kidney disease, actually 140 over 90 is reasonable. Sometimes people are surprised when I send back my letter saying that actually I'm fine with 140 over 90 for this patient. But this is why, now that we reviewed it, you see there just isn't that same evidence there in a non-proteinuric patient with kidney disease to push them down that low. Okay, so that's targets. And then I think the third big question here with management of kidney disease patients is, does the drug matter? Or specifically, the question is, who gets RAS blockade, right? Because that's obviously what we're talking about here. So in the non-diabetic, non-proteinuric population, right? So basically, even if they have some early kidney disease, but not those groups of patients, there's really not any evidence to say we must choose a different drug. So you can treat those people essentially as anybody in the general population. It's, again, surprising. A lot of us, I think, are just used to starting an ACE inhibitor or an ARB in anybody with any kidney disease. But if they don't have protein and they don't have diabetes, actually, there's not really evidence to do that. Here, when I'm to preface all this, when I'm asking the question of who must get RAS blockade, the reason it's important to understand this evidence is, although practically we might still start a lot of people on an ACE or an ARB, and that's fine, just because there are other benefits to these drugs. It's important to know the evidence base, because that tells you how strict you're going to be with it. Or the term that I use sometimes is who has a firm indication for RAS blockade, right? The patients who we're going to show in a second, where there's trial evidence to support better outcomes on an ACE or ARB, that person needs to be on it. Whereas somebody else, let's say they end up with some hyperkalemia or they have an acute kidney injury and they don't actually have one of those firm indications, you might say, actually, I can use any other medication. And that's why it's important to know that distinction. It tells you how hard are you going to try to keep them on the ACE or the ARB. So non-diabetic, non-proteinuric, there's really minimal evidence. So really, you can use anything. This is from the ALL-HAT trial, right, of saying you can use any of these first-line agents. I put this here just for when we put the slides out, just because I like this little picture. I'm a picture type of person, and this is why it's kind of nice. And you can see here that it shows, I like this first box here before we even talk about pills, about all of the non-pharmacologic things we need to do. And I'm going to come back to that a little bit later, actually. But then it tells us, how what we want to do for our medications. You can see it kind of talk a little bit about whether it's protein or not. This figure tells us to start with everybody on an ACE or an ARB, which again, I think is very reasonable, but we just need to, as we review the evidence, need to know how strict we're going to be about that. Otherwise, I just put this here because I like good pictures, and this is a good one. Okay, so there's a lot of trials here in patients who have high degrees of proteinuria and ACE inhibitor. And I didn't show all of them because we'd be here for a while. So this, again, is a nice little meta-analysis of it, that this is specifically patients who have protein of over 1 gram per day and using RAS blockade. And you can see that we have both renal outcomes, and this is end-stage renal disease or end-stage renal disease and doubling of serum creatinine, which is our pretty standard renal outcome. We now use that as a major combined kidney outcome, kind of like we do for MACE. And so things are better in patients specifically on RAS blockade, regardless of their blood pressure control, there was a benefit if they had more than 1 gram of protein. Oh, and sorry, this is all non-diabetic patients. And what's even more interesting, just like the blood pressure targets, is the more protein you have, the more benefit you get. Okay, so looking at this figure here, what this shows is you see the baseline protein going up, right, up to 10 grams. And yes, we see our nephrotic patients with 10 grams. And this shows the dropping of relative risk. So you can see the benefit they get gets larger and larger and larger the higher their degree of proteinuria is. So just like we talked about with blood pressure, I'm going to be more strict to get them to the target, the higher their blood pressure is. Same thing with an ACE or ARB. Someone with an ACR of 50 or whatever, yeah, it'd be nice to have them on, but not the end of the world. Whereas someone with an ACR in the many hundreds, they have to be on this drug because they get a much, much stronger benefit from it. Okay, and then so diabetics, and here we've got some great landmark trials too that we still talk about, again, almost 20 years old, but we still talk about these because they're such strong benefits. So this is IDNT, where we took patients with quite a bit of protein, so over almost about 1 gram, right around there, and they were randomized to an ARB or amlodipine or placebo and titrated to their blood pressure. So everybody gets a similar blood pressure control, just different drugs. And we see a clear benefit of the ARB in our diabetic patients with a fair amount of protein as listed there in terms of everything. They didn't get a change in just death alone. There wasn't a lot of outcomes in this trial, but every renal outcome they had a strong benefit in. The other one, which is around the same time, Renal, which you still hear us talking about as nephrologists because they're dramatically positive and we don't have a lot of positive trials in nephrology. And same thing, this one actually they pushed the protein a little bit lower, right? The last one was almost 1 gram. Here now it's 500 milligrams and did basically the same thing. And again, despite the blood pressure control being the same, the patients who are on the ARB specifically did better in terms of all of these renal outcomes. Okay, so this was the one that I was kind of building up to, and I mentioned a few times. Now we've talked about all of these different trials, and I want to spend a few minutes here talking about the evidence. So I put them in different colors because I think when we look at a guideline, it's important to look at the grading because that tells you where is the strong evidence and what's basically an opinion statement. And that in turn tells you how strict are you going to be about that point, right? Because guidelines are just that, they're guidelines. We need to individualize our treatment a little bit. So when we're looking at all these, we need to know, is this someone I'm going to be really strict about what number I'm using and what drug I'm using? Or if the evidence isn't really that strong for that type of patient, maybe I have a little bit more flexibility and I don't have to be quite as strict. That's the way to look at that I want to look at this slide. So I'll go through these couple of points and then we'll look at the numbers. So again, remember that when we're talking about targets, the evidence is all from the protein. The evidence for lower targets all comes from proteinuric patients in the chronic kidney disease world. There are other groups of patients like SPRINT who have, not kidney disease. That's a different story. When we're talking about kidney, it's all related to the protein. And similarly, when we're talking about the RAS blockade, yeah, it might be a good idea for a lot of patients, but it's specifically about the protein again, where we are going to be strict about wanting to be on RAS blockade rather than a different drug. Now, I want to put this caveat, and that's why I didn't show it here, but there are other reasons that someone's going to be on an ACE inhibitor specifically. Similar to SPRINT, there was this trial called HOPE a little while ago where they took patients at higher vascular risk and they did better with RAS blockade as opposed to some other antihypertensive agent. So and there's a lot of overlap in the kidney patients where they obviously have a high vascular risk. So there are other reasons that you might want to start with an ACE inhibitor. I think that's very, very reasonable. But again, in that patient, or if you're having trouble keeping someone on RAS blockade, this informs you to say, how strict am I about it? If there's someone who's got a lot of protein, you know that you're going to give them a lot of benefit, at least in the kidney world, for them to be on RAS blockade. And so you're going to be much more strict about it. And that's what I highlighted in this tables, right? So this is all of our guidelines before SPRINT. You can see it was a big complex table. Post SPRINT, this is the one from KDIGO. They actually went, some people thought this was kind of controversial. they recommended the sprint target to everybody. They said everybody should be targeted to less than 120, which is a pretty aggressive statement especially when you consider that the trial didn't include a lot of our different populations with kidney disease, right? It didn't include patients with diabetes or high degrees of proteinuria. So they said that statement, they then, if you look through the body of this guideline, I think they did an excellent job. They said that's kind of your starting thought, but then individualize and realize you might need to back off in some patients if they don't meet that criteria, which I think is a reasonable statement. And you can see that's why it's a 2B statement, right? It's informed by some evidence, but kind of opinion-based, right? It to be 2B. Whereas when you look at the real firm evidence, it's around those points we just talked about. So we know we want to get people at least to 140 over 90. We've got very good evidence of that. That's not a surprise, right? But then we also know for the patients who either have diabetes or not, we want to make sure that if they have a lot of protein, they're on an ACE inhibitor, and there's a little bit more evidence to push them down lower. Okay, so kind of the approach we talked about before. Okay, so that was the whirlwind of evidence. You made it through. So I show, the whirlwind's over, the storm is over, made it through having to listen to a bunch of trials here. So let's talk about a few of the other considerations around blood pressure management. So lifestyle changes, we often don't talk about, but it's a very important thing. And, again, I could spend a whole talk here about this. I really like this one from Hypertension Canada, where they go through some pretty specific recommendations, right? Because I find that often a lot of things say we need to make sure our patients are physically active and work on their weight and all that, but what does that really mean? And it's kind of hard to just send someone on their way and tell them to do that. So I really like the way they've defined what do we talk about when we're saying physical activity to our patients. They've defined that nicely. They define alcohol intake and a specific DASH type diets, right? These are all kind of nicely defined. And this is the type of thing we do in our kidney clinics as well. A big part of what we do in our kidney clinics, we have dietitians who go through all of this stuff, and this is what we work on. So I don't think there's any surprises there. I'm mainly just putting this here, and I wanted people to look at that resource because it's a great one, the one from Hypertension Canada. Now, I wanted to talk about salt a little bit though, right? Because this is one where you sometimes see, and it's quieted down now, but a couple of years ago, even in the lay media, there was a lot of things around salt limits, right? And who really needs the salt restriction? Do you really need to push it that low to less than 2 grams, or what do we need to do about this? And I think that's sometimes the wrong conversation, right? Because I think where that debate comes from is that in the general population, sure, there's not a lot of clear evidence that lower is better in the general patient without hypertension or without chronic kidney disease. But the way I kind of look at it is that we know that some subset of people with hypertension and chronic kidney disease are going to be salt sensitive, right? And there's good trial evidence for this. We know it's not everybody, but the other thing we also know is, I'm a nephrologist. I've never seen someone who's come in sodium deficient in Canada, right? Or hyponatremic patients, even they have a different issue. It's not that they don't have enough salt in their life, right? So in other words, I think a lot of us do think the lower the better in general. So we can quibble about what's the absolute maximum salt target, but I don't think that's the right discussion. It's when we talk with our patients to try to get lower and to know what are the high sources, right? Which are really pre-processed and processed foods. That's where 90% of the salt in Canada comes from. To really know what's the high yield target and then to work on it and get it as low as possible, I think is the right message and a simple one that our patients can follow. And then the other thing I want to mention about salt is there is actually evidence that a higher potassium diet actually further improves things. And this was I don't know if anybody saw this. It just came out literally a week or two ago online. And when I saw this, I was kind of blown away where they used a salt substitute, which still has some sodium, but actually a fair amount of potassium. And it actually had a mortality and cardiovascular benefit in this group of patients. There's some other smaller trials about this, but this is one of the biggest ones to date. And you can see it's in the New England Journal, right? It's a pretty big deal to say that actually maybe a higher potassium value is a good thing. Just, of course, you have to be mindful that's hard to follow in our renal patients. So salt substitutes are probably a good thing, but then all of a sudden you got someone with kidney disease on an ACE inhibitor. It's hard for them to follow a higher potassium diet. Okay, and then the last item that I wanted to talk about there was about blood pressure measurement. So this is another, oh, sorry, I didn't credit this. This is from Hypertension Canada. I forgot to put a little thing at the bottom. This is a nice little figure from Hypertension Canada that they've actually changed their guidance on this over the last little while. So this is a pretty big statement that they've put out, right? That out of office blood pressure assessment is actually the preferred method to diagnose hypertension. Recognizing all the pitfalls when we try to check someone's blood pressure in the office, they've actually gone to say that it's superior. And because there is an evidence base for this, I'm not going to go through all the trials, but there is an evidence base that we more accurately get a representation of someone's true blood pressure to diagnose hypertension when we do it out of the office. Or the other way of thinking about that is if we're only ever doing office-based measures, we're probably diagnosing some people with hypertension who don't have hypertension. So this is why it's a better method for diagnosis. For monitoring, it's building, but it's not as strong as a recommendation. So they haven't gone so far to say that for monitoring, maintenance blood pressure in someone who has high blood pressure, they haven't gone so far to say that it's preferred for that, but the evidence base is building. Okay, so I think we're starting to see a shift, right? We're moving more and more into the patient realm, which I think is good. It empowers our patients to be actively involved in their disease, and we get more accurate measurements. So it's a win-win. So in terms of how we do this, first, I just want to touch on office-based measurement. It's not to say that office-based measurement isn't helpful, right? Some patients can't monitor their blood pressure at home, and you want to know if they have, if they're more or less on track there, right? So it's more the point that when you're doing it, you need to make sure that you're doing it in an approved way. And you can see this is the preferred method, right? So an automated, so manual cuffs, they're just not as accurate. I still have one. I use it for when the machine doesn't want to pick up a reading, but for everybody else, the automated one, it just is more accurate. And the way we should be doing it is, that's kind of what I do. I got it set up. You can actually see my machine in the corner. I didn't realize that in the video. Set it up, hook the patient up to it. It's set to cycle a few times. I actually step out of the room. That's when I go get another drink of water, have my coffee or what have you, go to the next person, let it run a couple of times, and then come back and check the measurement. And that's when we're measuring in the office, that really is the preferred way, because we know there's just inaccuracies in anything else. But then for home, how do we do this? So the gold standard, and I'll start on this side of the slide, the gold standard for out-of-office measurement is actually a 24-hour ambulatory monitor. Okay, so if we had a perfect world, what we would do is periodically we would have our patients wear one of these 24-hour ambulatory monitors, go about their day, and we would monitor their blood pressure. And we'd probably do that a couple times a year if we had a perfect world. But the problem is it's cumbersome, obviously, and as many of you are aware, also there's a cost associated to it. And in fact, blood pressure machines have become so cheap, including good, accurate blood pressure machines. They've become so cheap that depending on where you send them, the one-time cost to do a 24-hour ambulatory monitor could be almost the same as the person buying a unit. And of course, if they buy the unit, they can check it as many times as they want over the many years, right? So while it's still a good tool, that I think is its main limitation is the cost. In a talk like this, I don't want to talk about specific providers, but just suffice it to say that if you shop around, you can find people who are a little bit less costly. It's not just the lab who does this. There are other places, including some of the places that do, for example, sleep apnea testing and other testing like that. I'm not going to say providers, but if you shop around, you can find a lower price, which is a good thing to know. So it's the gold standard. And if patients, if cost isn't an issue, or if you really need to know it, it's a good thing. Where I think clinically it's the most valuable is when you just can't resolve a discrepancy between what you see in the office and what they see at home, right? The patient's always swearing up and down that, it's 125 at home. I never see anything like this. And in the office, they come in. Yeah, of course, we're used to calling that white coat, but I think that's where every now and again, at least as a one-off, I'll do that to correlate and say, you know what, they're completely bang on. They're correct. Their home values are much better. I've done it. I've compared the two, and then I can rely on their home blood pressure a little bit more. Okay, so that's 24-hour ambulatory. Now for home blood pressure monitoring, again, I think this is a great thing. We're actually in our kidney clinics in BC, we're in the midst of a program of work where we're really pushing this. We've even gotten resources to try to help provide some for patients who have trouble affording them. And we're doing a whole body of work to empower patients to measure their blood pressure at home. I'm a big believer in this, both again for accuracy and to empower the patients to have control of their disease. If you're doing it though, you really need to make sure that they're doing it correctly. Because I think that was sometimes our downfall. I know I've been guilty of this too. You would just tell people, okay, yeah, you've got a home blood pressure monitor, great, give me the numbers. But you never really checked, were they doing it properly? Can you believe those numbers? And the nice thing is there's a lot of great resources out there. We've developed a whole suite of resources in BC Renal that's available on our website right there, just bcrenal.ca with some nice pictures. And also, I can't say enough, actually, the Hypertension Canada ones are excellent. And we actually cite them and use a lot of them in our BC Renal ones, a lot of the same figures and things like that too, because they're excellent. I love this little figure. I think it should be plastered everywhere. I actually tell patients to print it out and put it by their little, wherever they check their machine at home, because it's a great reminder of exactly what someone needs to be doing to make sure that you're getting an accurate number. Excuse me. So if you're doing home blood pressure monitoring, which I think we should be encouraging, just at the same time, you need to point your patients in the right resources to make sure it's done properly. Okay, and then otherwise, so the last pointer I want to leave people with, this is just kind of one of my pet projects, is that we have these resources, and some of you are used to seeing them mainly in our diabetic patients, right? These sick day medication lists, or SAD man's lists, some people call them, of medication changes when they get sick. I just want to leave this with people that I sometimes think these are a little bit underutilized. At least when I get a lot of referrals for, acute kidney injuries, and patients are on 4 of these different drugs and their blood pressure is 90, and all we have to do is adjust things a little bit and they come back up. So I'm mentioning this because I think in general we should be using this, right? Anybody who's on multiple of these agents, I think, should have one of these medication lists at home. But the other point I want to make is we always have it listed as a sick day medication, which makes us think, bad infection, flu, diarrhea, but also the same thing happens in the setting of, significant hypotension, which I told you was something we need to caution our patients for when we're using more aggressive targets. Right. So if somebody was used to, having a higher blood pressure, and all of a sudden we add these medications and they're on multiple different agents, we are going to run into similar trouble. Right. So just another little word there that as we push lower, it's something we want to be mindful of. Okay, but otherwise, that was the content that I had for you. It was a whirlwind tour, a lot of stuff here. Again, this could have been many different talks. We could have gone over this, but just wanted to reiterate that important interaction. And not everybody with hypertension has kidney disease because of that, and the vice versa. People with kidney disease completely unrelated have hypertension issues. So we wanted to talk about that. We wanted to talk about the blood pressure targets and choice of medications and where the evidence comes from. And if I'm leaving you with one summary point, it's protein. A lot, as we go on in the nephrology world, we realize that that's one of our strongest predictors of a lot of things, and it fits here. Protein is what tells us how strict we're going to be about a blood pressure target, and protein is what tells us how strict we're going to be about an ACE inhibitor. And then we wanted to talk a little bit about some measurement methods for blood pressure, stuff we all know, but just how do we practically put that into place. And with that, I'll just kind of open up to our little chat box there and see if there's any questions. Oh, or actually, there's a Q&A box. Let me go. Right. So Casey has left a comment saying that she works with a lot of patients who have overlap between these various things: kidney disease, heart disease, diabetes. And yeah, this is the real world. This is, what our patients are. And they can be, her question was, it can be complex to set an individual targets, and how do we collaborate? I think this is really important. And this is something that I think we try to take on in the kidney world, where we'll say, this is a blood pressure target for this patient. And it needs to be very, very clear. And what we're trying to do in our kidney clinics, we actually have now everybody set, what is this patient's blood pressure target? So actually written on a piece of paper, and we want to put that in all our communications to one another. I try to do that in my dictation. I say, this patient's blood pressure target is less than 140 over 90, or less than 130 over 80, or whatever. And I agree, it's the communication piece. I think there might be some, I think it's there might be some individual preferences about how low they might push it. And you can see that's opinion-based, that's fine. I think the more important thing is the communication. So not just saying this person's on an ACE inhibitor, but I am specifically trying to target X and give a number. I think that's really the key here when we're talking about communicating with these patients and letting the patient know too. One of the biggest things we can do is empower patients to say, actually, I've been told this is my number. You know, if someone else wants to change it, that's great. They can talk about it, but the patient also knowing this is my blood pressure target, I think is a very powerful thing also. Okay, Kiyomi said, when do we stop ACE ARB when going down consistently? I actually often don't, unless people are running into trouble with their hyperkalemia. Even as I often will leave an ACE or ARB on right up until someone starts dialysis, for example, just because of the various different benefits. Again, it's not just for renal benefit that we're doing this. They get a lot of cardiac benefit, for example, out of it. So I don't want them to be off of it for a long period of time. If we do stop it, sometimes it's just that short period while I'm kind of rearranging and maybe trying to buy an extra month or two to get their dialysis plan in place, where I'll pull it and then restart it after they get back on. And that's fine too, because it might make their potassium, for example, more easy to manage. But I would just say, remember to put it back on. It's because sometimes that gets forgotten, right? We'll stop it before dialysis and then it gets forgotten. And they do derive cardiac benefit from it, right? A lot of these patients. So we want them to be back on it later. Okay, another question was, do we have comments on pre-diabetes or impaired fasting glucose and salt? Any thoughts about pre-diabetes consideration might contribute to it? Yeah, I mean, it depends exactly where someone's at in that trajectory, right? I think, you know, if we've got someone who's a type 1 and you kind of the writing is on the wall, I'm a lot more inclined to treat them aggressively early, right? Someone who's type 1 and you know they've got many decades ahead of them. Treat them early, which includes all of this: salt restriction. I'll get them on an ACE inhibitor. I'll target a lower blood pressure because they don't have established valvular disease or anything like that. They can tolerate a lower blood pressure, right? So someone like that, I'll be much more aggressive up front. Whereas if this is someone later in life, I think the decision really is about what do you predict their outcome to be, right? I get patients every now and again who's got impaired fasting glucose, but they're 70. It's like, well, do I really think they're going to both develop diabetes and then see renal consequences of it within the course of their life? You know, maybe not. So that kind of informs my decision of how aggressively to treat those patients. And then as far as the salt, I actually tell anybody who's at risk even of developing kidney disease, you know, we all have way too much salt in our diet anyways. I think that conversation about what's the maximum allowed salt, as I said earlier, I think that's the wrong conversation. I think we should be saying, you know, do people in general stand to benefit from having salt a little bit lower? Probably. And do they stand to benefit from having more potassium in this population? Yeah, probably. And a lot of it comes to do with foods that have potassium with it tend to be real good foods. You know, so yeah, I would suggest those things for this type of patient. Okay, great. Okay, and oh, my sharing went off there. Okay, I think, oh, and did recommendations change for patients on dialysis? Nina, thank you. It's a very good question. And, you know, that's where I often, with my dialysis patients, think what's driving their outcomes here. And for most of them, it's their vascular outcome, of course. I think the one thing that changes, though, is they do become, as you've seen, a little less tolerable of lower blood pressure. So to me, that's actually the more important factor for my dialysis patients. I think they all have an established cardiac equivalent if they haven't already had cardiac disease. So I would ideally like to target them lower, but I think the real question in those ones is how low do they tolerate? And that's often what I'm limited by. I find in dialysis patients, often I'm saying, you know what, I'm even fine with 150 over 90. So anytime you try to push lower than that, they get dizzy and all kinds of things happen because they just don't have that same auto regulation. So I find that's more the limitation for the dialysis patients, what's tolerable. Great. Okay, well, I'm not seeing any other questions. Otherwise, thanks all of you for the attention. And, you know, we'll have these slides go up recording, and you can always refer back to it later.
Mike, did you see Angelina's question in the chat box?
Nope. Okay, hold on. Maybe I got the wrong one. What was the K level? Oh, interesting. So they actually, it wasn't a K level. So sorry, the question was, what was the K level in that high K trial that I referred to? It wasn't a K level. It's that they actually had them use, instead of salt, one of these salt substitutes that I believe was 25% potassium and 75% sodium. They did pull people, I forget the exact, what they defined. I think it was 5.5 where they would then pull people. I'd have to double check that. But it wasn't targeted to a K level, because if you have normal kidney function, the potassium in your diet isn't going to make your serum potassium go up. It was just liberalizing the potassium in their diet. Great. And the other question, yeah, and Sidonia, I think that's correct, right? This all gets posted on the BC Renal website after all of this. There's a question about the slides.
Yes.
Yeah. So this will all be posted up on the BC Renal website, and feel free to access it and share it around as much as you like. Great. So otherwise, we'll end there. Thanks all of you for coming and your attention and your questions.